Does site of lesion matter? What to consider when working with stroke patients? One of the most common diagnoses a medical SLP will encounter is stroke, or abbreviated as a CVA, a cerebrovascular accident in a medical chart. But what should SLPs consider when looking at those head CTs or MRI reports? I'm going to show you why this is important and what you can consider as an SLP when it comes to where in the brain the stroke occurred and what symptoms you are more likely to expect based on that information. Let's dive in. I'm Theresa Richard. I've been a medical speech pathologist for 15 years. I'm a board-certified specialist in swallowing and swallowing disorders. I'm the founder and CEO of the MedSLP Collective and MedSLP Education. So right side versus left side stroke, what is the difference? So a general rule of thumb is that speech and language are usually impacted with a left-sided stroke, whereas executive functioning and cognition are usually impacted with a right hemisphere stroke. Additionally, there is an association with worse pharyngeal dysphagia with right hemisphere CVA. However, this is not a hard and fast rule. A right-sided stroke does not always mean there will be pharyngeal dysphagia or cognitive impairments. And a left-sided stroke does not always mean there will be speech and language impairments. This is actually a really fascinating area of our field, and we have lots of incredible researchers doing some really great work on this ever-emerging area. It also depends on the specific area in the brain. Is it an ACA, MCA, or PCA infarction, which will all impact different characteristics. I remember earlier in my career not really understanding as much neuroanatomy as I should, but I had a wonderful supervisor who always told me that right hemisphere stroke patients were always so fascinating. I remember doing an evaluation on a gentleman who was very impulsive and said some really inappropriate things. I won't repeat what they were on here, but his poor wife was just so mortified. And she said he would be so horrified if he knew he was saying these things. She said he was always just such a polite and proper man, and she was just devastated to see him this way. I knew right away after hearing his responses and his wife's brief history that this was in fact a right hemisphere CVA. Sure enough, after doing a much more in-depth chart review, I was right. This man has stuck with me because it was so fascinating how the stroke impacted him so differently than what we think of with other strokes, where it might just be slurred speech or inability to formulate words. So what about the nitty-gritty, the specific site of the lesion? I'm talking about an actual map of stroke locations and the predicted outcomes they might have. One common area that should immediately put up a red flag for SLPs if you see anywhere written in the chart that the patient has had a lateral medullary stroke, MLS, or has had an occlusion in the vertebral artery or posterior inferior cerebellar artery. An MLS is also referred to as Wallenberg syndrome, and 51 to 94% of patients with LMS present with dysphagia. I remember I saw a patient about 6 years ago that had some really funky dysphagia symptoms. The skilled nursing SLP called me in to do a FEES on a man that said he was having so much difficulty even swallowing his own saliva. Sure enough, he barely had any esophageal clearance through the UES, and he presented with vocal fold paresis, both telltale signs of LMS. After further discussion with the nurse on the unit, she agreed to call the physician and get the patient sent back out for an MRI, where it was in fact confirmed that he did suffer from an LMS. This is really where we can be the detectives in differential diagnosis for these patients. Now, this patient did in fact prove my hypothesis correct, but sometimes we might just be the one that finds an impairment and suspects something else is going on. This is all part of the hypothesis that we're building so that we can justify the importance to our administration for the instrumental assessment and also educate our patients on what they might possibly be at risk for, so they understand why these assessments are so helpful. In this particular instance, the SLP knew for sure that something wasn't quite right and ordered the instrumental assessment. And between my findings on the FEES and her initial observations, we were able to get this patient out to get him the help that he needed. Investigators have been digging into methods for correlating brain injury with the symptoms that are presented for years. As technology advances, we're learning more about direct relationships and correlations between specific brain site lesions and symptoms. This information is extensive and goes far beyond what this video alone can cover. But here are just a few specifics I can share with you now. According to one model, known as the dual stream model of speech, deficits in the production of speech are more likely to occur if the dorsal region of the brain is impacted. The dorsal region includes the middle frontal gyrus, anterior and posterior insula, putamen, and globus pallidus, just to name a handful. So you might predict apraxia of speech or reduced speech rate if these areas are impacted. The dual stream model of speech also implies that deficits in comprehension are more likely to occur if there's damage to the ventral regions of the brain. Ventral regions include, but aren't limited to, areas like the angular gyrus, superior temporal gyrus, and the middle occipital gyrus. Spastic dysarthria is associated with upper motor neuron damage in the motor cortex. Ataxic dysarthria is associated with damage to the cerebellum. Hyperkinetic and hypokinetic dysarthrias are associated with the basal ganglia control circuits, which include the caudate, putamen, and globus pallidus. Impaired relaxation of the upper esophageal sphincter, which can cause severe pharyngeal dysphagia, is associated with damage to the brainstem or medulla. Before we get to the third point here, to tie it all together, I'll be posting other videos just like this one that you won't want to miss. So make sure to hit that subscribe button to make sure you keep up to date with topics dedicated to you, the medical SLP. So why does this matter? Understanding where the site of lesion is located and its association or direct link to impairment type can improve your ability to diagnose, treat, and predict the type of impairment after the stroke. I have a colleague that reported that she had a patient with a normal head CT, but the video fluoroscopy showed unilateral pharyngeal residue and reduced UES relaxation. She was in acute care, so she called up the neurologist to suggest follow-up brain imaging, preferably an MRI, with a focus on that brainstem medulla area. Turns out there was a 3mm acute medullary CVA. If we see a patient with a brainstem stroke, we can predict that there is likely an issue with reduced upper esophageal relaxation and increased risk of aspiration, and from there, we're able to create a treatment plan to help rehabilitate the swallow, but also create compensatory strategies to decrease aspiration in the meantime. If you're interested in learning more information about this topic, I've got a free gift for you that digs into this. Brain Damage and Impairment, a brief overview of brain behavior relationships. In this resource, you'll find evidence-based information on brain behavior relationships specific to SLPs with an excellent list of references at the end. You can find that at medslpcollective.com/brain, and we'll stick it in the description below as well.